Welcome back after the break. Next up, we want to talk about how to improve data interoperability for better patient outcomes. Here to talk about it, we have our panelists ready to start the discussion. Allow me to invite them one by one. Edward Kliphuis, partner at Sofinnova Partners. Edward, welcome. Edward Kliphuis, partner at Sofinnova Partners. Now, Alexis Edwards, associate partner, IBM Healthcare Consulting. Joining us, Jovan Stevovic, CEO at Chino.io. Robert Ługowski, CSO and co-founder at CliniNote. And the discussion will be moderated by Guillaume Duparc, partner at L.E.K Consulting. Guillaume, let's welcome our guests with applause, please. Let's test the mics first. If it's all working, I will pass to Guillaume.
Is that working? It's working. So thanks very much for making it here post-launch. I hope we'll have a few more people joining very shortly. So we're here today to talk about interoperability, and I have a very good panel with me that combines years of experience around data and systems, but also investing in the space and maybe the hardest challenge of all, digital transformation. With Alexis at IBM. So I'll let my panel members introduce themselves a little bit more in a minute, and essentially we wanted to start the conversation with them outlining a good example of interoperability in which they are either have implemented or in the middle of or about to start. The topic is obviously very important, given how healthcare data is still very much siloed, and this is the case in Europe. It's a bit less the case, but still in the US. But there's a lot of things to work on to leverage all of this data. So I thought we would actually start with Jovan, who has an interesting example of hospitals collaborating together with secondary use of healthcare data and with a program, I think it's called AI Accelerate, that's sponsored by Horizon and the European Commission. And it'd be great, Jovan, if you can outline a little bit what is really the objective of this program and how it came together and how it was made possible.
Thanks. Thank you, everyone. My name is Jovan Stevovic. I'm CEO co-founder of Chino.io, a company helping other companies and startups building products and solving data-related challenges, privacy, security, and certifications. And I've been working on interoperability since 2010, first on primary level of interoperability, connecting hospitals and social care services. That's one type of the challenge, but right now in different projects, and in particular, for example, one on AI, we are presented with another layer of interoperability challenge. How to connect different hospitals across Europe and enable secondary reuse of data, enable research on AI, building digital twins, building digital care pathways that are common between hospitals in Finland, in Spain, in Italy. And so in these research projects, we are using the data, existing data, in the silos, in the single hospitals, or sometimes also in connected hospitals. Like, for example, Finland is a good example where things are really connected and interoperable. But we need to access to this data and analyze some common health issues across different countries, use this knowledge, perhaps not data, because at this level of secondary usage, we don't want to share real data. We want to share the knowledge that we are extracting from the hospitals. So typically, we are talking about edge computing, synthetic data, and anonymization techniques that makes this interoperability possible in order to create the AI solutions that are common across hospitals. So I think, and this is also connected now with the European strategy on the European health data space and different topics that we are seeing, regulatory changes to enable reuse of health data, because we really need it, because GDPR is great, we work on that, but it's also creating obstacles for secondary use of data and research. So, and this type of interoperability is really necessary at European level.
Thank you, sir. So we'll come back a little bit later on the European Health Data Space Initiative and these data federated platforms. We have, some that's coming in the UK. There's some that will come later on at EU level. But you don't, need to wait for governments and policy making to make things work. There are other ways to work around leveraging data and making the most of it. Maybe, Robert, you want to talk to us a little bit about, I think, a partnership you just signed or just about to start, or just about to announce as to who else than policymakers are interested in making the most of this data.
Thank you. Robert Ługowski, CEO of CliniNote. CliniNote has developed the technology that helps to get the highest quality data out of the medical notes without putting additional burden on doctors, which we know that it's a problem. So we have many use cases of this technology, but probably from interoperability point of view, the interesting one could be the one that we have in oncology. As being said, interoperability is not only about the technical layer, it's much more about semantic and understanding what really doctor or healthcare professional meant by putting some data into the system. So our technology works in a way that we actually help doctors to co-create the note. We have this copilot with the use of NLP and AI, but used prospectively. And that's feasible to have this understanding. And that's why this technology is being used in a number of projects in that area. So the one that was mentioned, it's our cooperation with Novartis on National Oncology Network. There is a new law, like 2.5 years right now in Poland, that according to National Cancer Strategy, there should be some quality metrics done on every oncology hospital in Poland. And that means that they should collect more or less the same data and with the same understanding to provide on 3 levels and to report. So we implement, so the project was announced actually yesterday. It took us a while with all this discussion, but we are in this project 1.5 months, and the experience is that it's extremely important that to work with doctors to create technology in a way that they understand what's expected, but we also, technologists, understand what the data really means, and in that way we can facilitate it on technical level. So what we do is that we use more or less similar data structure in all the hospitals in a network, but it can be adopted to the needs of a given hospital, clinic, or even the doctor, because we simply put the block of text and the data is generated according to some algorithms that we defined. The rest can be done as they used to do it. So there is a flexibility to have this adopted locally, but also to be interoperable on a national level. And when it comes to European Health Data Space, maybe later on I will also share some experience from European projects.
Indeed, but maybe I think one point when we discussed to prepare this session, I think is really important, and we'll come to, there's many challenges to achieve interoperability, but certainly, there's a need for better structured data. And for those of you who work with clinicians, the last thing they want to do is spend more time on admin. So Robert, you might be aware of these statistics that come from the US. A bunch of clinicians were surveyed. About 36% of them spent more than half of their time on admin rather than patient care. 36% spend more than half of their time. So imagine the amount of care that can be additionally provided. In addition, about 72% of them indicated that they were worried about the need for more data entry, and that would be a key reason for them to leave their organization. So whereas there's multiple challenges to achieve interoperability and deliver on the benefits, certainly helping the doctors to be efficient with data capture, whether it's with predetermined chats or whether it's with natural language processing or whatever other solution, that's going to be an important driver for doctors to really contribute, and without them, that's not going to be possible. Another example, Alexis, I think you want to talk to us a little bit about health information exchange, as it were, which is a product that's more and more common in Europe and also of course, in the States.
Yeah, sure, thank you. So I think we've heard throughout the day that we're really at a critical inflection point in terms of the sheer volume of data that's available. And we understand better, based on the technologies and the examples that were just given, on how to harness the power of that data. And as you said, there's also sort of a demand from consumers, both citizens who are looking for greater autonomy and transparency of their data, but also from clinicians who are really looking for greater efficiency gains and for better insights and to be able to empower data-driven decision-making and intelligent clinical workflows. That can only be achieved, though, if we have interoperability, and that's based on really common core data standards that vary, of course, across different regions. We heard earlier about the US and their common data standards for interoperability. The NHS has a data dictionary, and that supports, of course, their emerging data standards. So it's really important that we have kind of robust governance around data standardization. We've talked a lot about data quality and data cleansing, but I think more importantly, we also need to think about data enrichment. And the way that we do that is by bringing together these disparate data sources across different providers and systems. And of course, we know that as humans, we aren't, we're more than a sum of our parts, right? We're not ICD-10 and SNOMED codes, the social determinants of health that make us up the remainder of our lives account for over 80% of our clinical outcomes, as opposed to just, maybe our diagnoses and some of the symptoms that we're facing. So bringing together and linking data across systems, so bringing that primary, that secondary data together is really important. We're really looking in the NHS at how we bring in local authority data, school data, to be able to achieve that sort of 360-degree view of an individual and to be able to establish a longitudinal health record. And there's various ways to be able to do that. Of course, one is through sort of the health information exchange, which is a more centralized approach to secure information exchange across different systems. So this works really well in private systems like the US or the Middle East, where you have a myriad of different providers doing both primary and secondary specialty care, and you also have payers that are involved in that data, and they need to see the transition of individuals through those systems. And obviously, if they don't have those data sharing agreements in place and a way to securely exchange that data using HL7 or FHIR, then the data remains really siloed. We see a similar thing happening, though, in the NHS, where even we heard earlier about the pivot towards integrated care systems, which will join up the data more at a local level, but we still don't have a national view, which is, for a universal care system is really less than ideal. So they're looking at the implementation of the NHS Federated Data Platform, and other federated data platforms exist across Finland, Singapore, other nations. And that's really more of a decentralized approach where you allow for distributed data sources to have autonomy over their data and to manage it accordingly. But then you have a centralized roadmap using some of the techniques of edge computing and pseudonymization that allow for that national analytics, which is really important to be able to help us drive better decision making and prepare us for the introduction of predictive analytics and personalized medicine and AI. But in order to get to that point, we have to have that data in a standard and accessible way. And that hopefully will help us to drive, a more digital engagement approach as well and improve outcomes over time.
Thank you, Alexis, and we'll come back to data-federated platforms. But first, Ed, you can talk a little bit in your capacity as an investor as to, why the heck would you want to, put your money into that space? It sounds very complicated, and the benefits, I think, we could come back to this, are, clear, but it can be hard to achieve. So what excites you about the space, or where? What interest do you have, or how have you thought about this space to date?
We're very excited about the space. So guys, I'm Edward. I'm a partner at Sofinnova Partners, and I co-lead our digital medicine practice, which broadly invests in everything to do with data and computation in medicine. Now, investing in interoperability is not just about optimization. It is really a space that we believe is existential for what we're actually doing here. Because on the one side, there's sort of a technology readiness level, which is data and computation coming together, and finally the data being able to be turned into information that is actionable. That's important. Just data by itself is rather meaningless. Now, that's all great and that's all fine. But the second part is that we now actually have a market need. And that is really driven by a rise of cost of healthcare as a proportion of GDP, a change in the demographic pyramid, and as exemplified by the NHS, more people dropping out of practice than actually coming into practice. And so we believe that these efficiencies that basically the combination of data and computation can unlock are fundamental for making sure that we can deliver the care that actually individuals deserve. Now, how to do that? There's two different vectors here, two different parts sort of that we're interested in. The first one is connecting different data sources around the same individual. So this is, for instance, if you go to the hospital, you get your you get a biopsy, you get, for example, radiology or sequencing information. That information is hard to interrogate in the same place. So we invested in a company called Betteromics that exactly does that. How can you make that information interrogatable in the same place as a single source of truth? And then as a sort of a second step of that, there's the metadata that comes of this, right? If you think about, for instance, things like simple laboratory tests, normally when you do a blood test, only when your biomarker is outside of the range do you get an asterisk and do you get sort of like questioned by the doctor on that. But where you sit in the range and what the interplay between the various biomarkers is, that's lost. And so we invested in a company called Kiro that does that. Now, the second part then is to actually connect all these different data sources in different places together. And we believe that's more of a policy play. And that's more of a play for larger players like IBM, like Amazon. And so that's where we keep tabs on the market to see where the development of sort of these bigger players, the nation states, the big corporates are going. So we do what we can on the sort of like the more venture capital backable use cases, and we keep tabs on where the large movement is going.
Thank you. And certainly as I understand the investments you've made, you're more into investing on how to generate insights from these various data sets as opposed to trying to connect them together or manage the access rights and the sensitivity of that data and privacy concerns that citizens well, certainly across Europe have in mind. So whereas there are policy initiatives moving on in the US, there's been a range of policy deadlines last year and this year to be more interoperable. There's better standards compared to Europe. Alexis mentioned it's frightening, but a head scan is coded differently from two radiology departments, even if they belong to the same group. I was talking with DAS Lab this morning. Network of labs don't even code things consistently within the network. They might not even conduct the analysis in the same way. So there's a lot of work around to do there. There is a policy initiative at a European level around the European health data space, and part of its adjacency around data-federated platform or standards, for this. Robert, you're a little bit involved with some of these pilots. What can you tell us more as to how this is moving? And is this, is there a real path to something real, or are we in a world of, this is big projects, and mind you, and Alexis will know that well, with an NHS context, the range of big project failures and wasted money has been quite substantial. So what's your take on the European health data space, or at least the pilot, and what's coming up at the moment?
I think we all share some passion about what technology can bring to healthcare, and I really hope that we will have these regulations in place soon. However, it took a while to prepare. Regulations have been announced beginning of May last year, not adopted yet. European elections in Q2, so hopefully it will be adopted. And we start the preparation. Talking about the pilots, we are I can share experience from two of them. They are on one hand similar because the goal is to get the data, share the data. There are hospitals, usually top centers from different European countries. In one it's 15. It's called DG1. It's a pan-European federated network of cancer comprehensive centers. And the project is driven a bit top-down by IQVIA and some industry partners. It's a private-public partnership. The second project is called IDEA for RC. It's more scientific project, bottom-up approach, also federated learning, 11 great hospitals, and a lot of discussions between scientists. The outcome is that, first of all, it's extremely difficult to agree what kind of data we want to collect, share, and of course how. The second that I previously talked about, it's important to have all the stakeholders involved and across the whole value chain. So in some of these projects, it's the focus just on sharing the data. And this is difficult if you don't take into consideration the data input and also how the data is to be used. And last but not least, as I said, is to make it working in a way that partners from different maturity levels can use these tools, can contribute and can benefit from something that we create together, which is not an easy thing to do.
Yeah, no, and there are many challenges. I think one thing that sort of reassures me a little bit is not everything, but a lot of the European health data space is linked to Finland, who's been a driving force in that area, and certainly they've. Maybe you guys will disagree, but certainly within Europe, they are the most advanced on connecting the dots across data sets. They've been at it for a very long time, and whether it's public or private, institutions, there's a lot going on. So I'm reasonably positive as long as they stay in charge, so to speak. So I'm very keen if members of the audience, have questions to raise their hands and come on to. Asking our panel members, a topic, and I can see already someone with a question. Maybe Klaus, do you want to, colleague who volunteered some question, do you want to speak a bit loud and I'll repeat the question as needed?
Yes, close to the panel, so people are very curious.
Let me use the mic.
Oh, perfect.
Much better.
Question around interoperability has been in healthcare for a long time, and there used to be a standing joke, it's what everybody wants and nobody really wants to pay for. But one of the questions I had is, with the rise of generative AI, do you see a step change in interoperability potentially happening within the next, I'd say, 1 to 2 years, especially in the interpretation of unstructured data or potentially data that's structured differently? Because it's originating from different companies that have different types of setups?
So I would have loved if the panel was on that, because large language models hold the big promise of being able to capture the individuality of all whilst benefiting from the knowledge of all. So it is sort of like the ultimate step to precision medicine. Up to this point, we've applied engineering approaches to biology. which you simply cannot do. Like we might, all be sort of built roughly the same way. On an executive level, our proteins, our expression profiles, they're all different. And so what really is the key to that is the generalization part, right? Looking into the unknown and the unseen and really extrapolating from what is known. That's really where we see this, because if you think about the data interoperability, what is the biggest challenge? That we have public healthcare systems, yet capitalist movement on the other side. And those two will never find the same mechanics of actually coming together. There's going to be policies there, there's going to be, look at Cyphius in the US, the moment you collect information on patient-level data and a Chinese investor comes in, the US government freaks out. So synthetically approaching that problem might well hold the key to all of this.
I think just to build on that as well, it's also the triangulation of those measures that you're speaking of, but also outcomes, and we haven't been able to do that before, and so hopefully generative AI will help us in that space as well.
Our experience is in two dimensions. One, of course, that all these top global LLM players, they would like to train their models, and they come to companies like us, because we are in this triangle between patient, doctor, and some system, and working with these live suggestions, we can see what doctor selects and train the model. Using this technology, we experimented, and we do have some components in our, but this is in European settings quite challenging, not from technological, but from legal and especially responsibility point of view. And it's like with like with self-driving cars. The technology is there, but who will take responsibility?
Yeah, no, I would agree, Joe. I would echo the sentiments that, before these large language models, but I take your point, Robert, that as soon as you move across border, it becomes way more complicated. But if you say already within the border of a country, if you were in a world where you had to map how company A or hospital A map its data versus lab B versus extremely intensive, and the only mechanism really that worked at scale was, well, promise some of that data insights to pharma to get pharma to invest into the project and pay clinicians to basically rewrite the data in a structured fashion. But I think now we've come across at L.E.K with Klaus a number of examples where large language models can actually achieve maybe 95% of this. So it's not perfect, and we haven't checked the hallucination sort of level, so to speak, but I have good hope that at least within a region or within a country, that can naturally accelerate that move.
If I may add to that, I actually, sorry, maybe...
Yes, you are.
If I may quickly comment on that, it's less of a problem than you think. Because if you think about how the GPT models were trained, they were trained on a database called Common Crawl. Common Crawl is open source. We have the same for biology, 60 billion parameters. It's less of a data problem because the data is there. You need to complement that. It's a money problem, it's compute, and it's a people problem, talent.
Yep.
We're there, we can do this. It's literally just the next step of investment.
Yeah. No, thank you, Ed.
Thank you very much,
Thank you.
dear panel. Thank you for an excellent discussion. Applause, please, ladies and gentlemen.